Welcome to this webinar on expanding the basket of contraceptives and introducing long-acting methods. I will turn over the first introductory comments to my colleague Poona Mutreja. Poona Mutreja, as you all know, is the Executive Director of Population Foundation of India, and she is well known to everyone in the field, and she has been working very with all of us on advocating for family planning for a very long time. Over to you, Poona.
Okay, thanks, Deepa. And you'll do the introductions later of everybody else. Okay, wonderful. So, very warm welcome to our rather large welcoming audience today. People are very tired of webinars. And so we have been very careful. We have only selected what we consider the most important issue. We have not been having endless webinars, and the few that we've had have been well attended because we've been very careful in respecting people's boredom with webinars. So, before we start, let me just take a minute to state that the worst of the second COVID-19 surge is partly over, but not fully over. In the cities, yes, but not necessarily in the villages. And all of us, in one way or the other, I know our current panelists and others have been through the experience of losing someone or someone being very ill. All of us, in one way or the other, have been affected by the virus. I'd like to extend strength and courage to those who have lost loved ones and request all of us to follow and promote the three big behavior change that we need to do for a long time to come, and perhaps much of our lives, which is masks, physical distancing, and vaccination. But after what we have experienced in this country, I think what we need is compassion for each other. What we need is to really be supportive, not just to each other who know each other, but to society, which is really suffering. Some people might be wondering why Population Foundation of India is organizing this webinar in the middle of the COVID at its peak and crisis. Um, COVID is raging everywhere and disrupting lives. So you would be right if you're asking the question, but honestly, I don't think any of you would disagree if I say that for the last 18 months, we have seen huge disruptions in the provision of family planning, reproductive health services, which have impacted families, especially women's lives. At PFI, we continue to focus on family planning while we are working on COVID-19. We see this as a COVID response when women are not getting services on this today on this International Day of Action for Women's Health. We are deliberating on a critical issue of availability and accessibility of contraceptives, of choice of all women, no matter where they live. We are focusing and we continue to be committed to choice for all women, no matter, as I said, where they live. Expanding the range and reach of contraceptives to everybody is what we pledge for action. And that is the objective of the webinar today. It is a fundamental right of every woman across the world to access family planning. Women in countries like Thailand, Bangladesh, and Indonesia have greatly benefited from the expansion of choice, and especially one very important contraceptive method, long-lasting contraceptive method, which is implants from in their public health systems. Given its long efficacy for 3 to 5 years, it would have been the perfect one for us to have at this point of time when access to family planning services and many other services is difficult also the community is scared to go and access services because, as we all know, the disruption of services has put enormous restriction on women's reproductive health and services. Um, so discussing access to current basket of choice, deliberating on family planning self-care options, telehealth and inclusion of new LARC is a reasonable ask, I believe, given the circumstances, more so in the given the COVID crisis. It is even more relevant how current and potential family planning users are currently facing countless challenges in accessing services. NFHS 5, I'm referring to the first phase of NFHS 5, reported an increase in the use of modern contraceptives of family planning in all the 17 states. And as you all know, that injectable, for instance, had been introduced during the period that the last last NFHS 5 looked at. And family planning declined, unmet need for family planning declined in most states, except Meghalaya, Andhra Pradesh, to mention a few states. And this is an increase, and indeed encouraging and motivating for those of us who are involved in family planning programs. At the same time, we must pay attention to the variations that exist in these indicators across various states. For instance, there are districts where unmet need has remained the same or has increased considerably in the last several years, 7 to 8 years. So therefore, it's very important to promote practices that have contributed to an increase in the uptake of contraceptives. NFHS 5 findings reveal that the largest contribution for increase in CPR at the district level was due to the frontline workers conversing with women on family planning programs. We know that successful family planning programs are those which talk to women. We have global evidence, and we have most evidence from India today, given the role of ASHAs and the time that ASHAs came in and started promoting contraceptives. We need sustained efforts and strategies that expand, inform voluntary contraceptive choice, which offer a range of contraceptive methods, providing client-centered, comprehensive family planning, counseling, ensuring continuous supply of contraceptive commodities, and sustained social behavior change. Communication both have got affected at this point. NFHS 5 also reported a decreasing divide between urban and rural areas, which we absolutely welcome in contraceptive use, indicating that more rural households are using contraceptives in the last 5 years. This achievement can be further accelerated through meaningful engagement with PRI members, leaders, district collectors, block development officers, and as well as grassroots organizations, of course, and other departments. And PFI, with the grant earlier from Bill and Melinda Gates Foundation, in collaboration with, where we worked in collaboration with the lead organization at Johns Hopkins Advanced Family Planning Program, demonstrated that at the district level, if you do proper planning, monitoring, and supporting and strengthening supply and other systems, it is very successful. And this is an evaluated program, which many of you would have heard. PFI was the lead partner, and we were joined by 5 other very eminent NGOs working in the field of family planning later. And we worked in states across, in 5 states, and with good results. So we know that the availability of and accessibility to current contraceptive basket is restricted by the ongoing and during the ongoing Pandemic Population Foundation of India is constantly gathering information, then sharing it with both the state and central governments. I'd like to highlight a few issues that family planning reproductive health organizations and partners are experiencing during the ongoing wave. And many of you would be familiar, so pardon me for listing them out. As we've heard from the field, from our colleagues, as well as from NGOs across. So there is a low acceptance of family planning services by clients. This is primarily due to limited access to services. There is also significant apprehension among service providers during the second wave, where they fear getting infected from clients. Most primary healthcare centers and community healthcare centers have converted into COVID-19 care centers, and rightly so, but limiting access to sexual and reproductive health. In general, family planning services have been seen, unfortunately, as a low priority, and sterilization services have naturally stopped in most areas. The gap in sterilization services is being compensated with the provision of long-lasting reversible contraceptives such as IUCDs, injectables to some extent. And however, this is taking place in very, very few places. So there is, ASHAs are overworked. We all know that. They have taken the burden of COVID more than anybody else within in the villages, in the at the block level. Overwhelming crisis brought in due to current infections. The ASHAs are just not available, and understandably so, for family planning. I'd also like to mention a few things that can be implemented in the current circumstances that had also been highlighted by CEOs, CSOs and experts. But Deepa, I think it will be good if I do that a bit later during the discussion, as we are all very eager to hear our very distinguished panelists. Deepa?
Thank you very much, Poonam, for the context, for setting the context for this webinar. I will now introduce and I will introduce all three of our panelists and request them to make their presentations. We will have a Q&A session at the end of all this when the speakers have made their comments. And please insert your questions in the Q&A section, the Q&A box. With that, let me start by introducing our panelists. Our first speaker is Dr. Jaideep Tang. He is the present Secretary General of FOXI and the past president of the Mumbai Obstetrics and Gynecological Society. As you know, he's been very active on the topic of safe abortion. He holds several key positions in various international networks and organizations, such as FIGO. Our second speaker is Dr. Beena Joshi, who's a clinician and with a PhD in public health. She's presently Deputy Director at ICMR's National Institute of Research in Reproductive Health and is based in Mumbai. She has also worked for several years at Family Planning Association of India. And our third speaker is Medha Gandhi, who oversees the Bill and Melinda Gates Foundation's policy initiatives on family planning, as well as maternal, newborn, and child health. Medha has been previously has worked with the IPAS Development Foundation, and she was a national consultant on adolescent health with Government of India. With that, may I invite Dr. Tang to make his remarks. He will speak about the private sector engagement for expanding the range and reach of contraceptives. Dr. Tank, over to you.
Thank you, Deepa. I hope my slides are seen and I am audible.
Yes, yes.
Yeah, thank you, Poonam. So let me first begin by echoing whatever Poonam has said, and I do agree with whatever she has said in fact, and I also do believe that there is a strong case for private sector engagement for expanding the range and the reach of contraceptives. I think it's probably a little underappreciated fact that globally more women and children may die due to the consequences of inaccessible and inadequate health services than will perish from COVID-19 itself. And we do accept the fact that contraception saves lives. And if we do accept that fact, then it stands to reason that the lack of contraception or the lack of access to contraception is detrimental to women's health and their lives. Another underappreciated fact seems to be that nearly 70% of frontline healthcare workers are in fact women. And I'm afraid that not enough attention has been paid to this particular subgroup of women and their reproductive needs. I do believe, as I already said, that there is a case for engaging with the private sector much more than what we already have, particularly for these kind of issues. The question, of course, arises as to why do we need to talk about private sector? And that second sentence, which I have made in bold, perhaps answers that question quite succinctly, that the total private infrastructure accounts for nearly 62% of all of India's health infrastructure. In fact, there are some states where the capacity of private infrastructure exceeds the capacity that is available in the public infrastructure. And I'm not really talking only about the physical infrastructure. I'm also talking about human resource over here. One of the issues that I have seen over the years is that we unfortunately treat the private sector as this one big homogeneous entity which responds to the same kind of incentives, which responds in the same way to various kinds of programs. But this could really not be further from the truth. If you ask me, the private sector is both heterogeneous and extremely fragmented. If you look at the various models in private sector healthcare that currently exist in this country, for example, a doctor running a specialty in a hospital, owning a hospital, or having a JV, etc., you'll realize, and it's quite evident, that the economics that play out in every kind of private sector healthcare setup are very, very different. In fact, are much touted big chains, though that's again the last sentence in bold there, that four of India's largest publicly traded hospital chains lost 63 billion Indian rupees between 2016 and 2018. So much for hospitals making a huge profit. The key, however, I believe, in approaching private sector, and particularly for issues like reproductive health and contraception, is the fact that almost 80% of services are provided by the small hospitals. And the definition of small hospitals given here is hospitals with 1 to 25 beds. In fact, it's estimated that small hospitals provide healthcare to almost 70% population of this country. And it's rather strange when I see a lot of strategies which are more geared towards large corporate hospitals rather than these single doctor or single physician kind of setups, which actually account for the large majority of healthcare. And that's why I say that even within the private sector, when you talk about engagement and partnership, you probably will need a different approach depending on what kind of private sector setup you are approaching. Well, I'm sorry about that. My slides. Right. I hope they can be seen again. I accidentally clicked on the link.
Yes.
Yeah. So as I was saying, private sector is not this homogeneous entity which can really be lumped together. It does require a lot of nuance to approach every part of the private sector if we are going to get the most out of them. This is a very recent article which I read, and it essentially talks about the fact that the private health sector in India seems to be ready and willing, and yet it has been underutilized in the COVID-19 pandemic. To a large extent, I think a lot of reproductive health services have indeed been given in the private sector, and Foxy has put out several statements supporting the fact that reproductive health needs should not be ignored at the cost of treating only COVID patients. However, and I'm going to stick my neck out a little bit here and say this, that I strongly believe that physicians usually, initially at least, don't become doctors simply to make money. I can tell you that there are many easier ways to make money. I strongly believe that people become physicians because they have this, what I like to call this altruistic gene in them. And I think it is up to us to engage them. It is up to us to engage with the private sector and leverage the kind of infrastructure, again, both capacity and human resource that they have, to make sure that the women of our country benefit from this sector. And that's why I think it's high time that we start asking the providers what they want. You know, I read a lot on what patients want, which is absolutely necessary, of course. But I think when an equation has two sides, you need to address both sides of that equation. And I really have not seen enough literature which seems to ask the question, why do providers behave the way they do? And what do providers want, which will prompt them to engage in reaching out to the community and providing these kind of services. And I think this can really be a focus area. So the first focus area could be different approaches to different types of private sector setups. The second approach is talk to the providers, try and understand why they behave the way they behave and what will encourage them to participate in these kind of initiatives, leveraging what I talked about, the altruistic gene a little earlier. However, and I think this pandemic has quite clearly shown that you cannot look at the private sector in isolation. There are supply chain issues, there are issues of last mile deliveries, and there are issues of disrupted access where services and resources are diverted from regular, and I hesitate to use the word regular, but I am going to do that over here, regular healthcare to healthcare which focuses only on COVID. And that is why I think public-private partnership is probably going to be quite instrumental in the way forward for engaging with the private sector rather than just leaving the private sector and leaving it up to them to expand the reach of contraception. These are all the various models of public-private partnerships, and I'm sure all of you have read about this before. But the essential point of a public-private partnership, and I say this as someone who is currently a service provider in the private sector, is that public partnerships are all about balance, maintaining equilibrium between public and private, risk and reward, cost and impact. Unfortunately, the way most public-private partnerships actually seem to be drafted is to skew them in favor of the public sector, whatever that may be policy makers, maybe bureaucrats, etc. Unfortunately, we need to balance this out and create a win-win situation, because successful public-private models require willingness from both sides to participate. And while from the government's perspective, the private sector can play a crucial role, the private sector's perspective of minimizing and mitigating risk, because ultimately they are businesses, make them reluctant to engage in public-private partnerships. And that's why I always say that there is a merit in looking beyond monetary incentives for private providers. For example, transparency in administrative processes, single window for permission. I can tell you, I run a nursing home. It's not a very large hospital. It's around a 22 to 25 bedded hospital. And I need something like 27 licenses, some of them which are renewable every year to keep my practice going. We need to avoid stringent and disproportionate regulations for the standard of care. And needless to say, we need to treat healthcare providers with respect, assure safety, and improve infrastructure. And there has to be some incentive for that. At the end of the day, when you talk about the private sector, you are talking about an entrepreneur or an business. So besides this, of course, we need to. Yes,
Dr. Tang, if I may ask you to wrap up in a couple of minutes.
Wrap up? Yes, sure.
Yeah.
That's actually the second last slide. Thank you.
Thank you.
So we also need to look at regulations, methods, expanding the basket of choice, and how private sector can play a role with that. And lastly, I'd just like to say that let's not think of the private sector as only private hospitals. It is much more than that. There are companies which look at telemedicine, which can facilitate and expand the reach. You have apps, the e-pharmacy, one of them just reached unicorn status, and of course, pharmaceutical partners, and they all have to be bought into the net of the partnership. Finally, as we start seeing light at the end of the tunnel, as Dave always said, in the rush to get back to normal, let's use this time wisely to decide which parts of normal are worth rushing back to. And I certainly think that private sector engagement is something which is worth rushing back to. Thank you very much.
Thank you, Dr. Tang. We will hold our questions. We have a lot of questions, of course. We will hold them for the end of the session. May I now invite Dr. Joshi to provide, her presentation would provide insights on the study on implants that she was involved in. Dr. Joshi, over to you. Dr. Beena Joshi, you're muted.
Yeah, hello. Good afternoon.
Would you like to turn on your video while you're speaking?
Yeah. Yeah, good afternoon. I'm sharing my screen. Can I have access to share screen?
Can our tech folks please help?
Yeah, you already have the access time being a panelist. There is a button share screen. If you click that.
Yeah, I'm not able to access my presentation.
So, Deepa, should we go while Dr. Joshi figures that out?
Can we have maybe Medha can, or is that your screen?
Is it visible?
Not yet. No. Maybe while you get it fixed, shall we proceed with Medha?
I'll just coordinate with Dr. Joshi.
Okay. So Medha, please.
All right, thank you. So it's really tough to go after Jaideep because he makes such strong points and such relevant points. I will, as I speak, I will speak from the perspective of keeping girls and women at the center and trying to figure out how we can focus on, Dr. Joshi, we can see your slides now. Deepa, would you want?
Yeah, since we have the slides up,
Yes.
Dr. Joshi, would you like to continue with your presentation? If you can, please keep it to about 8 minutes. Thank you.
Thank you, Medha.
No, absolutely, because I think this is important to hear. I'm happy to go after that.
Okay. Thank you.
Dr. Joshi, we're waiting for you. We can see your slides. I think there's still some technical problems.
Give it a second, Deepa.
Yeah, we just wait.
Poonam, Deepa, would you like to take maybe 1 or 2 questions for Jaideep that came up in the
Yeah, why not? We have.
Yeah, am I audible now?
Yes.
And my screen is visible?
Yes, your screen is
Yeah, thank you so much. Yeah, very good afternoon to one and all. At the outside, I like to thank Poonam Mutreja Madam and Irfan Khan for inviting me to share our work on the cost effectiveness of introducing Implanon in India's family welfare program that we did on the behest of Ministry's question to Department of Health Research. We have published this work in the Applied Health Economics and Health Policy Journal. And I'll take you through a brief presentation on the work that we did. You might be aware that ICMR had conducted a large-scale clinical trial across 22 sites on implant contraceptive with a very good method effectiveness and a very low loss to follow-up rates, and the discontinuation rates were also pretty low. So our aim was to conduct a health technology assessment to assess the incremental cost utility ratio of Nexplanon for its potential program introduction in India. And the method we followed was the population that we considered were women of reproductive age group 15 to 49 years. The intervention obviously was the Nexplanon contraceptive, adding it to the existing basket of choice, with the comparator being the current contraceptives in the program, all the current existing contraceptives in the program. And the outcome was incremental cost utility ratio, which is nothing but difference in cost by difference in the quality adjusted life years or QALYs gained. And also we looked at maternal deaths and unintended pregnancies and childbirths averted. So basically this is an economic modeling exercise, and we use the decision analytical model, which is the Markov model. Basically, I will try to just take you through this diagram. We looked at a hypothetical cohort of 15-year-olds.
Dr. Joshi, yes. Are you moving your slide, because we are still seeing your first slide?
I am moving slides, madam. You're not able to see the slides?
No.
I don't know.
I think you're on your fourth slide, but we can't see it.
Is the model visible?
No.
Can't someone from PFI please move the slides?
Is it visible now?
No. Do you want to share your slides with us so that we can project it from here?
Dr. Beena, may I request if you could continue with your presentation?
Can you continue with your presentation
because you've not shared the slides with us, so we can't upload it from here. So may I request, in the interest of time, if you could continue without the slides? Thank you very much.
Yeah. So we went through, we used the decision analytical model, which is a Markov model, and basically it takes the hypothetical cohort of 15-year-olds through a life cycle approach until they reach menopause. And the model it considers different health states that a woman would pass through in terms of not using a contraception to begin with, to moving to other modern methods or using permanent methods. And she could remain in a particular health state of using any contraceptive method, or there could be method failure resulting in unintended pregnancy, and the outcomes of an unintended pregnancy being ectopic pregnancy, abortions, vaginal delivery, or cesarean delivery. And in the model, death is an absorptive state that is to be considered. So the time horizon that we considered for this model was around 31 years, and the cycle length for each of the Markov model analysis was about 1 year. We considered the health system and the societal perspective with a discounting rate of 3%. We had a systematic review done to assess the clinical effectiveness of Nexplanon, and we also conducted a meta-analysis on the continuation rate. This is also a published paper, and the clinical effectiveness rate was very good, with a Pearl index of less than 1%, mostly ranging between 0.1 to 0.4. We also looked at the NFHS score data to assess the transition probability. So it was a primary analysis that we carried out. There were other targeted search for other contraceptive methods to assess their clinical effectiveness. We also did a targeted search for utility scores for health-related quality of life, and estimations of costs was done using a primary micro-costing study using a bottom-up approach at 5 facilities in Maharashtra, which included a medical college, a district hospital, sub-district hospital, and a primary health center. The model was constructed in Microsoft Excel, and we derived at package cost for each of the contraceptive methods, and also the cost that would that the health system would incur to meet the other outcomes of unintended pregnancies in terms of abortion, ectopic pregnancy, whether it's a vaginal delivery or a cesarean delivery. So with these costs and the utility scores and the clinical effectiveness, the model was built. And for the model was run twice. One with the current scenario of basket of choice of methods, and the other model was run for if the Nexplanon was included within the basket of choice. So we got to know the incremental costs and qualities that would have incurred by adding Nexplanon to the existing basket of choice, and the incremental cost utility ratio was derived, which was about INR 16,475 rupees. And the difference in outcome indicators between the two scenarios was also considered, where what are the maternal deaths, numbers of maternal deaths in terms of whether it is an existing scenario or when an Nexplanon is added, what are the number of deaths that would be incurred during the entire process, unintended pregnancies, childbirths, and abortions. And it was very welcoming to see that the numbers averted were larger in the Implanon scenario compared to the current scenario with the existing basket of choice. Now putting these ICER values on an ICER plane, you can see here that the cost effectiveness was in the right upper quadrant, where which shows that it is well below the threshold, GDP threshold per capita, which was in 2019 to be around 1,37,945 INR. So it proved that this was a very cost-effective strategy to include Nexplanon within the contraceptive basket of choice. So this Markov model was run for 1,000 simulations using a probabilistic sensitivity analysis, and it showed that the 1,000 times the ICER values fell very close to the base case, which showed the robustness of the model. Then sensitivity analysis was done to ascertain if there was uncertainty in the input parameters and to assess what are the factors that could affect the ICERs. And one of the important factors that could affect the ICERs was if we increase the number of contraceptive users, the ICER values would further reduce, which would mean that it would become more cost effective by having more number of people using the method. We also conducted a budget impact analysis looking at parameters in terms of number of eligible couples and the estimated acceptors of Nexplanon. We also had the budgets, annual health budget and the annual family planning budget for the center. And hypothetically, we proposed that the introduction of Nexplanon could be done in a phased manner. Start with the tertiary medical college to begin with, and then slowly roll out to the district hospitals and sub-district hospitals in the second year and third year to the PHCs. So we calculated all the expenses that would be incurred by the health system to meet the number of eligible couples who would use Nexplanon, and we realized that the net savings, there would be net savings in the bargain. The scenario analysis was also considered by varying the contraceptive acceptance rate between 0.2 and 4%. Most of the times, most of the studies showed that the Nexplanon use was maximum about 4%, and the total expenditure still remained to less than 1% of the total annual budget. So we had a few limitations that we accounted for all the costs, but not all the benefits were accounted. Whatever the contraceptive benefits are umpteen, not only necessarily the unintended pregnancies, etc. But we did calculate all the costs, but not all the benefits. The utility weights were derived from studies that were done in Western settings, and the primary costing study was also done at limited facilities due to little time that we had. We didn't have enough time to do a very large scale study, and the out-of-pocket expenditures were derived from NSSO. Yes, sir. Last slide.
If I may, if you could just do the recommendations.
Yeah.
Thank you.
So adding Nexplanon to current scenario was found to be very cost effective. However, we need to consider programmatic challenges. We need to conduct a feasibility and acceptability study before introducing Nexplanon in the program, and also address inequities in terms of rural women also having access to these methods. We need to have proper counseling and training modules for management of side effects and follow-up and tracking mechanism, because in the first year of use, these women who use Nexplanon do have a lot of side effects in terms of intermittent spotting, bleeding, heavy bleeding, or at times amenorrhea. So counseling and access to service or care is very, very essential. So there is a need to do a pre-program introduction study before it is directly taken up into the program. And I acknowledge all inputs received from various people in the team. We have submitted a policy brief document to the ministry and have had several discussions with Dr. Sikdar, and I'm just waiting for it to be taken up in the policy further. Thank you so much. Yeah.
Thank you, Dr. Joshi. I think that was a really interesting study. Our participants would benefit from receiving the slides. We couldn't see them, so maybe if you share it with us, we will make sure that our participants receive it. As well as if you can, if the policy brief is something that is public and you can share with us, that would also be really helpful. For everyone listening in, may I request you all to stay on for another 15 minutes just to account for all the technical challenges. And I didn't want to cut Dr. Joshi short because she had really important insights to provide all of us. So with that, with your permission, I'm going to extend the session for another 15 minutes. I'd like to call Medha Gandhi to speak about what, from her perspective, what she sees are the most important initiatives that we can undertake to see that stakeholders would increase, the availability of contraceptives in the basket of choices. Thank you.
Thank you, Deepa. I think we've had a very interesting conversation thus far, talking about the critical role that the diverse health sector, and I'm not going to just say private sector, I'm going to say the whole health sector, which cannot be just divided in public and private. Even the public has so many dimensions, whether we look at it from a medical college perspective or we look at it from a primary healthcare perspective. And in the current time, the focus on realizing the need to strengthen the primary healthcare structure, making sure that services are available closer home, and also realizing the diversity of the private sector. And focusing on channels. How do we really work towards strengthening of these channels and how they're important specifically from a women's health, a family planning perspective. And having said that, another thing that I think we'd like to think a little more on and focus on is how do we acknowledge the need that women have for exercising choice. Now, for the longest time, we've had this very method-focused approach where we've had a certain number of methods, and it's just believed that the public sector is the largest provider of family planning programs because we have a very method-focused approach. And if we look at it from the point of view of sterilization, if we look at it from the point of view of, say, IUCD provision, yes, the public sector may be the largest provider. But if you look at the private sector data on oral contraceptive, you look at the private sector data, which includes the social marketing data on emergency contraception, it's a fairly significant response to women's unmet need for contraception. So to say that the role of different channels does not exist would be a bit of a miss. How are we accounting for that in terms of data will require us to shift in our focus from a method-specific approach to a client-focused approach, where we're accounting for choice. We're not looking at the woman as a patient, not looking at the girl or the woman as a patient, but as a client who has the ability to take an informed decision. And we're providing her the tools to be able to exercise that choice and provide respectful care and services. We've really imbibed the whole concept of respectful maternity care. But I think when we talk about the continuum of care, we need to be able to provide respectful information to girls and women about taking informed decisions and choices about contraception that have an implication on the pregnancy that they choose to or not choose to have. And then post-pregnancy also, whether it is post-pregnancy family planning or whether it is post-abortion family planning, it's really important to keep the whole concept of women-centric or respectful care in that whole continuum of care process. So my focus would be on all of us here. And I think the onus lies on everybody on this call, all of the organizations that are committed to women's reproductive health and rights, to focus on looking at strategies for expansion of choice, expansion of channels. And when we're doing, the whole thinking around expansion of channels, really thinking through on what method is best suited at what channel level so that we're responding to women's needs. And when we're looking at expansion of choice, yes, we're having a very detailed conversation today around implants because that seems like a logical next step, but that's something that we are thinking we need to offer to women. But what is it that we can do in expansion of categories? What are we doing in terms of strengthening pericoital contraception? There is so much that needs to be done, whether it's looking at emergency contraception. So it's really making sure that women are able to exercise their choice. And I'm just going to take 2 more minutes highlighting one data point and a quote that resonates with me very hugely. Is that if you look at the NFHS data, which Poonam you alluded to at the beginning of this webinar, one data point that really sort of called out to me was this fact from 16 states where we've seen significant increase in use of traditional methods. And this includes states like Bihar, Assam, West Bengal, where we've seen very different, very, very dynamic trends in MCPR also. But we've seen significant change or increase in uptake of traditional methods. And I think this requires some bit of inquiry that women are exercising their choice. Women are taking their decisions. Does it mean that the methods that we're offering to them are not responding to the needs that they have? Or it is that they're looking for some other methods? Are they looking at spacing more and therefore not wanting to get into a complicated health system perspective? So I don't have the answers, and I'm not sure if what I'm saying is what women are wanting to say, but I think this is an area that requires a bit of an inquiry so that we're able to design programs that are responsive to this trend that women have exhibited. And to the point that Jaideep had made at the beginning of his intervention, which was around the disproportionate impact of yet another disease. And with C19, we've seen that there is a disproportionate impact on women and children. And even within the realm of provision of services, with women being at the front of it, are we really giving the right kind of priority to girls and women? And I'm always reminded of this quote that I'm sure we've all often heard by Dr. Mahmood Fatala. And that is, women are not dying because of untreatable diseases. They're dying because societies have yet to make a decision that their lives are worth saving. We have not yet valued women's lives and health highly enough. And that is very important for us to remember as we design any program, any intervention. And even if we're thinking of contraception, if we're thinking of family planning, that has a huge implication on the mortality and morbidity that girls and women face. I'm going to pause there and hand it back to you, Deepa and Poonam, for the next part of the webinar.
Um, thank you to all our speakers. Medha, that was a very powerful comment you made at the end, because I think while we are thinking, while we are ourselves considering which kind of contraceptive choice and which channel we use, also are we doing it in the private sector or the public sector or the CSO sector, let's keep women at the center of what we are proposing. With that, we do have a series of questions. I'd like to start with you, Poonam. You were beginning to say, describe some of the impacts that we have seen on the ground. Would you like to comment some
Yeah.
more on that? Thank
Yeah.
you.
Very quickly, first of all, I really want to thank Dr. Tang, Dr. Joshi, and our friend and colleague, Medha, partner, not colleague, I wish she was a colleague, but partner in the field for really giving us very different, uh, uh, helpful information, perspectives, today, just what we needed to take forward the conversation on expanding choice, which is our focus today, and along with existing methods, greater access, which you very articulately spoke about, Medha. So I'd like to mention a few suggestions that could be implemented in the current circumstances that have also been highlighted by CSO experts. And many of the CSO experts we work with are at the seminar, and we are very happy to see close to 90 people who have joined us today and continue to stay with us. So LARC LARC and temporary methods need to be prioritized to mitigate unintended pregnancy, as access to permanent methods is hampered in the second wave of COVID-19 infections. This is, I'm sharing with you, as I said, what the experts in the field have said. Ambulance mobile vans, which I mentioned earlier, should be mobilized to transport and distribute contraceptives, condom pills, and as well as sanitary napkins, and also administer injectable contraceptives. Engagement of chemists. Medha, you spoke about how we still need to do more work on emergency contraceptives, and you're absolutely right. And it is in that context, actually, this conversation of engaging with chemists and non-traditional outlets could be strengthened to increase and maintain supply of contraceptives. For instance, we talked about condoms being available in grocery shops or kirana shops. Leveraging the COVID-19 crisis, CSOs could strategically engage with government to advocate for the inclusion of contraceptives. Implants were specifically mentioned in by many of the CSOs when they gave us feedback into the basket for a long-term protection. So Population Foundation and our partners, CSOs, technical experts present here today, have played a significant role in sustaining and amplifying conversations with MOHFW and other key stakeholders in ensuring FPRH remains a critical public health agenda. And given the current situation, greater engagement with the government is needed uh, to support the government in fighting the epidemic, and supporting, here I'd like to say, supporting Dr. Beena Joshi and ICMR in the conversations that they're having, fruitful conversations they are having on implants. How can we play a role, Dr. Joshi, is a question that I have to you and to Dr. Tang, who, Foxy and ARC and PFI have collectively made a statement, but what can we do going further? And Medha, from you, who has a deep understanding of how the Indian public health system and the ministry works, if you can also add to suggestions on how not just PFI, but this 88 organizations that have joined us today, what advice the panelists have for us, and then also suggestions from the participants, and I really look forward to a lively and productive exchange now, and to develop a consensus, hopefully, on immediate priorities we need to go to the ministry with. And finally, I would like to say to we were very conscious and say to all of you, respectful of people's time. And so I believe we underestimated the time, given the importance. Deepa has asked for additional 15 minutes. So we have now 20 minutes. And I'm very grateful that all of you have agreed to stay. So over to you, Deepa, for the Q&A.
Yeah, thanks, Poonam. So Dr. Tank, you have a question, Poonam posed to you, as well as we have a question from Jayashree Nair, who's one of our participants. She is asking whether implants are available in the private sector, and what has been your experience in that regard, if they are, and what is really stopping the government from introducing it in the private sector? The last question, I mean, there may be others.
In the public sector, Deepa,
in the public sector. And on the last question, we may have Dr. Joshi, who would also like to come in.
Can we ask Medha, Dr. Tank, and Dr. Joshi to
please put on your videos? Yeah.
And so will I.
Yes, please.
And so should you, Deepa.
Yes. Just trying to. So, Medha, please put on your. So, Dr. Tank, would you like to address the question of implants in the private sector?
I think there was one question from Samarjit about how private sector should be engaged in demand generation and in awareness generation. And I would have to say the very short answer to that would be the same way that the public sector is engaged. What works for the public sector also works for the private sector. However, there is a certain amount of how do I say, less bureaucracy, if I may use that word, in dealing with the private sector, particularly when you're talking about this heterogeneous kind of private sector that I referred to. Remember that most private sector units in our country are single physician run, and it's sometimes much easier to work with them rather than work with large bureaucracies. So I hope I have answered that question. About implants in the private sector, I'm sorry to say that they aren't really available as freely as one would like. And there are a lot of limitations from the industry partners who are producing the implants right now. For some reason, they seem to be hesitant in scaling up the availability of the implants widely across the private sector. Poonam, if you remember, we had that meeting where we had invited the industry partners, and we had talked to them, and we had offered them a lot of help. And at that time, I had said that let's separate service delivery for particularly implants into 3 silos. We have one is the private sector, one we have is the NGO or the not-for-profit sector, and then the public sector. And as I said, we need to approach different things for private sector, differently for the not-for-profit sector, and differently for the other thing. Unfortunately, I really haven't heard too much from them after that. So I'm sorry to say that the amount of implants that would normally have been placed simply haven't been placed. And I don't think this is a limitation only from the physician's point of view. It's a limitation of availability. It's also a limitation about the scaling of the training, because implants do require a certain amount of training. And unfortunately, that training has not really been made available as widely as it should be. What is stopping the government for introducing it? I think we'll have to ask the government that, like we have to for many things. I think, but Dr. Beena might be able to tell us more about that.
Yeah, thank you, sir. Actually, after we completed the study, we were hoping that Dr. Sikdar would take this evidence base and push this into the policy. And he was so very enthusiastic about this. And he didn't give us enough time to do the study as well as we would wish to in terms of primary data collection, because there is really no data available on policies, on costs for all these. And so we wanted to do a very elaborate exercise, but he was very, very much in a hurry. And later on, we realize that this is not the only evidence that goes into policy making. There are so many other factors, and one, I do not know if it is still true in terms of Atmanirbhar Bharat. This is a product that has to be imported, and so there are a lot of apprehensions from the policy side to bring this into the program. I also feel while we have to do that advocacy at that level, we also need to assess the women's perspectives on using of such contraceptives, how comfortable they are, because our experience with injectables, as much as I know, speaking to the program managers, the first dose of injectable is well received, but then the second and third dose continuation is still a big fallout. And with these hormonal implants, again the story is to do with menstrual side effects, the intermittent spotting, bleeding, excessive bleeding, and of course the amenorrhea part. So a lot of effort needs to go into creating a sustainable or enabling environment for women to make this choice to use the implant. Again, who would be the right people in the public health system to insert the implant, and at what level can we take this implant? So of course it would have to be MBBS doctors who will be able to have this surgery skill to who are trained to do this. So there are a lot of things that can be done as a preemptive before it is finally taken up. So there are a number of studies we could initially think of undertaking, is what I feel, to assess the needs, the perspectives, and also the training needs, the IEC needs, etc., to try to bring this into the bringing this into the program.
Thank you. Thank you. We have a follow-up question from a participant, Dr. Budi, to you, Dr. Joshi. She's saying that a different device was tried out at the time of your study, and there are different devices available now. Would that make a difference? And perhaps Dr. Tank, you might want to respond to that as
well. I remember the study was done with the Implanon Next, which is having the radio opaque material in it, unlike the earlier Nexplanon study that Dr. Malabika conducted at ICMR many years ago. But when we considered for this particular HTA study, we did consider the new device. Dr. Goody, if I might have answered your question.
All right. So Dr. Pandey asks, how can we ensure, because it's not the matter of just introducing new contraceptives, it's how do we ensure equal access of all methods in the basket of contraceptives? I mean, this is something that all our panelists have been speaking of. Is there anything additional that we can do? Because we do know that there is a problem of continuation of temporary methods, and the family planning program has really suffered quite a bit because of that. So what is it that we can do? What additional steps can we take in that regard, in addition to introducing more contraceptives?
I'm happy to start to answer that, and I'm hoping that Jaideep and Dr. Veena Joshi and Poonam will join in. And I will start from a point that you made in framing that question, that we've had a problem of methods not being continued, and we consider that as a problem, because I think we're still coming from the framing that we're looking at a method being used and we're counting the usage of the method. We're still not looking at it from the point of view of a woman who's the user, and a woman may choose to switch the method that she wants to, and it's totally fine. Today she wants to use a particular kind of oral contraceptive pill. Tomorrow she wants to use a different kind of oral contraceptive pill because that's what works better for her. So she switched in a way, and we need to be able to account for that. And from an oral contraceptive pill, if there's somebody knocking at the window behind you, if she wants to switch from an oral contraceptive to to an injectable, and from that, in some time, she wants to switch to an implant, so be her choice. So I think we have to, while we're looking at providing proportionate what do I say, credibility to each method, we need to remember that it is the woman and her choice, and our ability to provide her the information so that she's able to make that decision. That being one very critical point. Another point that really calls out to me is how we position a method. Every time we talk about a method, when we only had IUCDs as LARCs, all our focus used to be on तुमको ये problem तो नहीं हुई. So the whole messaging got framed around what all goes wrong with a particular contraceptive. Today, when we're talking about injectables, we are constantly talking about the potential side effects or the experience side effects. There are so many benefits that a method offers. How much time and effort do we take to talk about the advantages that it offers to her? How much time do we take to build on the advantages to the provider, whether the providers in the public sector or in the private sector? How do we incentivize the method? Whatever method it is that we're talking about, when we're talking about condoms, how much do we talk about pleasure? Yeah, how much do we talk about taking the stress away of a potential unplanned pregnancy with the use of a condom? We don't want to do that, and by not talking about the advantages of a contraceptive, we position the contraceptive a certain way. So I think we really need to relook at the way we position contraceptives, and I can see Poonam smiling, so I'm going to pause here and hand it over to Poonam to build on to that.
You articulated it so well, Medha. You did not sound like a donor. You sounded like your old days of activism, and I was smiling. I was very happy, and it was a deja vu.
The person doesn't change, and for me now, I get to have a larger role and look at broader ways of taking forward the work. So
absolutely,
keeping
Madam,
at the center,
and I'm going to nail you on that just now.
Can I also raise an issue?
Can I finish, Beena ji?
Just let Poonam finish and then we come back.
Though, I mean, I can see that Dr. Joshi is so excited about saying something. So if she really wants to, I'll go after her.
No, I just want to flag the issue of vasectomy. We are talking of expanding contraceptive choices by bringing in new methods. Vasectomy rates have almost gone to less than 1%. So when we are talking of expanding the choices, I think we have to reinvent the wheel and bring vasectomy also as one of our focus, and not only look at contraceptives available for women alone. Is the only thing I wanted to flag.
Okay, great. So I'm very glad you raised that, because male responsibility, male involvement is something that I and most of us have to admit we have failed in engaging men. We have failed in getting men to take responsibility. And Dr. Tang, I am not looking at you only as a man, but I'm looking up to, I've not heard you on this subject, so I hope you will talk about it. But I do want to say that every contraceptive has a side effect. Every contraceptive. And I've said that before, and I'm going to repeat now, and my colleagues get very embarrassed, but try abstinence. You know, the side effects of abstinence could be rape, could be so much frustration, anger, beating up women, not just rape. So I think I totally agree with Medha. Can we stop talking about only the side effects of contraceptives, whether it is implant, injectable, or even pills and so on? Every contraceptive has side effects. Why can we not talk more about management? When we speak to Siddhar, we have to talk more about management of side effects, and not why women aren't taking and why we shouldn't introduce. I saw introduction of injectables. Let me tell you my biggest disappointment, and I will say that publicly. I am very disappointed that we didn't greatly improve the family planning services with the bringing in of the injectables, I thought we'll do a lot. But I haven't given up. I am an optimist. So I'm hoping when implants are introduced and all the concerns and warnings and suggestions that Dr. Joshi suggested, we must take care. We have to manage the side effects, and we have to make, not in a fear mode. And finally, I would say to Medha, I'll come back to you now. You have both the role of, you have in you an activist, and you have now a new persona, that of a donor. And we know that, and having Deepa and I having been donors, I think there is something which is we give money, which is one smaller part of what we do. But we know it as donors, we have a huge convening role. And Deepa and I used to spend less time giving money, more time doing a convening role of trying to push our grantees on the table, ourselves, where we could, behind the scene, talk to people in the ministry. We used to meet, a whole lot of people. And, in fact, the file on injectables opened because of some of the advocacy we did as donors behind the scene. And I know that the biggest elephant in the room, in the development sector today, is the MGF. So you have a huge role and convening role. And I hope that working with you, all of us working together, Dr. Tong, with Dr. Joshi, Dr. Joshi, I really will assure you support from not only PFI, but all the people here. If I may, including the panelists, we will work with you and let's work together. Finally, it's not about only one contraceptive that I am crazy about, which is implant. But I want, even if one pregnancy can be saved, if one woman can be saved from having a choice and not having an unwanted child and not getting pregnant, we must give choice to women of India, just like Bhutan, Sri Lanka, China, forget the developed world, Indonesia, the developing countries have given. What's wrong in India that we can't do it? And we can improve and reimagine. And this is a good opportunity when there is the whole world and India. Nobody can deny our public health system is really in a weak situation. We need to reimagine it. We need to strengthen it. Family planning should be part of that discourse. It should not be left behind like it has been left behind too many times. In fact, even in the high-level report that the UPA government commissioned, with Dr. Srinath Reddy and my own husband were part of, even then, in spite of all my advocacy, they didn't put in family planning. So we have to, and access to family planning, we have to make sure that we remain not only committed to family planning, but advocating now. Let's not only wait for all the experiences, anxiety, deaths, everything we're experiencing. Along with that, let's keep family planning and expanding choice on our agenda. I've talked too much. Sorry, Deepa. You can stop me next time and not give me a chance.
No, I'm going to take away your microphone now. I want to thank all our panelists. Everybody has stayed over for another 15 minutes, and we really appreciate that. You want to say something else?
Can Dr. Trank not answer about men?
You're putting him on the spot.
No,
Okay.
I don't
Dr.
mind.
Trank, we'll have a one-on-one.
No. You want to say a few things?
No, I want to say this, and I regularly offer vasectomy to patients who come to me seeking permanent sterilization. And in the last few years, I don't remember the single male adopting that method. And the reason I think is that we are underestimating the power of the stigma that vasectomy carries with it. It seems like a very old story about the nasbandis and this and that and the other. But the fact of the matter is that stigma is really, really difficult to get rid of. Men are traditionally, at least in what I have seen in my practice, I have always found that the women are much smarter than the men. They seem to understand issues much more rapidly, much more clearly, and in a sense, unfortunately, are unable to speak for the men. And I think to a certain extent, that is the root of the problem. Men are not informed. They simply don't care. They look upon it as the woman's problem, not their problem, because they aren't going to carry the pregnancy. So that was one part, stigma, etc. But I think there is another deeper root to, I think, and Mida, I couldn't agree more with what you said. There is a deeper root to why women change methods. You know, when, and I speak this as a clinician. I'm going to go now in half an hour and sit in my consulting room and probably see some women who are going to come and ask for contraception. And for me, the two most important things which women ask are, doc, is it safe? Is it effective? And to answer that question, I have to tell them about the side effects. The problem is this bit of a distrust, if I may say so, which has seeped into society in general about questioning everything. Questioning everything is great, but at the same time, you know, you need to accept things at face value also at some point. So when we talk about talking only about the benefits and not talking about the side effects, think about the provider who's providing that contraception and think about the blowback which the provider will get if the provider will not talk about the side effects. The patient will probably come back and tell you, doctor, you didn't tell me this. You didn't tell me my IUCD could, transmigrate. You didn't tell me that my IUCD could get expelled and I could get pregnant and so on and so forth. And the last point, Deepa, if you'll allow me, is that sometimes as providers, we get too invested in the method that we have recommended. And when a patient comes to us and says, doc, I don't like this anymore, I want to change my method, we look upon it as a personal defeat, saying that, I suggested the method, how in the world do you not like it? And, that sort of, and that sort of attitude, I think, which Veda was also alluding to, where, we need to get rid of this. At the end of the day, we don't need to invest in the method. We need to invest in providing contraception to the woman. And I think that really is the key to the whole thing, isn't it? And this is really where apps, follow-ups, telemedicine could really play a very major role. And, I hope that I was not all over the place with my thoughts, but these were the three broad points I was trying to make: the stigma, the distrust, medical legal blowback, and the fact that we invest too much in methods rather than investing in women.
So Dr. Tank, you've done an excellent job of summing up the entire webinar, the discussions. So I'm not going to attempt to do that, except to say that the COVID has really given us an opportunity and to go to the government, to go to private sector, to go to manufacturers and really place the whole issue of how do we serve the people of India for all their health needs, whether it's COVID, whether it's contraception, men, women, how do we talk to them, the need for greater counseling, the need for greater technology. I have a feeling we do have an opening, perhaps once this immediate crisis is over, and we should be looking at how do we position all our communication, all our policy and engagement from that lens. So with that said, I want to thank all our panelists. I apologize for some of the technical problems we had, but this happens apparently with every webinar that I have been on. We do have some issues. We will host meetings on family planning, to continue with this conversation every month. So this is just the beginning of the conversation. We hope to have a similar engagement in the months to come, and I hope all our participants will join us in that.
Oh, Deepa's herself experiencing technical. So I will thank all of you, and I will also thank our team, Irfan Khan, who led the design of this webinar, and his whole team. And I cannot end the webinar without thanking the Bill and Melinda Gates Foundation for supporting us to do the work we do on family planning and giving us an opportunity to contribute to women's reproductive health and rights. Thank you.